So let me go fast through this. And really, the question is a clinical trial right for you? Me is the way you would ask it. And my answer is almost always yes. So I sort of hedged on that. And I think the things that you really need to take into consideration, both you and the physician, is there a standard care of treatment? Is there treatment that is targeted and effective in your state of disease? As Dr. Wayne showed, there are certain drugs that are effective in adjuvant therapy. And obviously, I showed you in metastatic disease. You know, when you're looking at a trial, is this the initial treatment? Has the cancer progressed after initial treatment? One of the really important things I think people don't always appreciate, and I certainly understand, but patients for trials have to be in good health and with minimal cancer symptoms and the ability to perform daily activities. Obviously, when a drug gets approved, it can be used in a very ill patient. But when you're trying to analyze whether it's effective at all, we really need at first to study patients who have minimal symptoms. And then I think when you're thinking about a trial, you know, the commitments can be great. And are they reasonable for you to go, whether the location, the time, the travel? Do you have the personal support and need for biopsy? So going through what are trials, which I'm sure you've heard, the phase 1 studies is really just to evaluate safety and understand the drug. The phase 2 trial is really targeting how effective the drug is. And certainly you wouldn't do a real phase 2 study as standard in a situation when you have a standard of care. And then the phase 3 is when you actually compare your drug or a drug to the standard of treatment. In immune therapy, not as often, but in targeted therapy like BRAF, there's an interest in personalized medicine and in immune therapy, but this applies to targeted therapy. And you can see that we treat all patients, but really, if we knew what the factors were, the molecular factors, the markers that I showed you, we could potentially target certain patients for certain drugs. And certainly this doesn't work around every patient. The middle figure is trying to show that someday we might have it. And that's sort of at least my view of personalized medicine and cancer therapy. The other personalized approach are these vaccines that are made up of unique mutations you find in your cancer. And these involve getting the tumor out, sequencing the DNA, looking for these mutations, then finding the immune cells are present, and then inject that with some other factor that can enhance it. So it's a huge amount of effort, and it certainly is specific. And the real question is, can it work alone or can it work in combination? And then I wanted to finish up with just talking how the trials we have in melanoma give examples of what we have and what I've talked about. So we have a phase 1 study, and phase 1 has morphed into a slightly different. We don't just look at toxicity. We're always looking for efficacy. And these trials, we escalate a dose, we treat multiple different cohorts, which might be different diseases or different state of diseases. And then we actually do some expansion and look for some efficacy based on all the other information and what is an area of unmet need. So it's really a phase 1-2 study we do. Then there's the phase 2, which is really a straight combination or single agent that's being compared to nothing. And I wrote 2-stage design because frequently in these studies, we start and treat a certain number and then add some additional patients if it looks promising. And certainly an example is combination immune therapy, which is the standard of treatment for brain metastases. And then there's a trial that it goes around the country that looks at targeted therapy with many drugs, trying to in terms of trying to give the same sense that I showed the figure. And then there's these other trials, which it's hard to say what they are. They're randomized phase 2. They don't require a huge number of patients. You look at several arms. You're looking at efficacy. You're not comparing each other, but in truth, you are comparing each other. But you don't get a definite answer. And then the last is phase 3 studies. And Dr. Wayne talked about one of the studies, and this is for high risk stage 2. There are also studies we have looking at immune therapy before surgery in high risk patients and patients who don't get any of their therapy pre-surgery. So everyone gets the same therapy, but one group get 3 of the cycles before surgery. And certainly another one, we're looking at combination therapies with or without GM-CSF, which might make the therapy more tolerable. And then certainly there are trials looking in the second line with Yervoy, either with or without a TLR agonist intratumorally. So I think that, I tried to give you too long a presentation, but an idea. Let me stop sharing my